Hi therapy students. We're glad to have you with us today. My name is Leslie Carson. I'm a physical therapist here at the Seating and Positioning Clinic, and my coworker J.D. Barton is also a physical therapist, and we'll be presenting to you today a few of the things that we do here in this clinic. So the last year has been very unusual, and we miss having you here. We hope to see you soon. But for today, we're going to be socially distanced, so I'm going to take off my mask so you can actually hear me. So the Seating and Positioning Clinic is within the state of Tennessee government agency group. Our particular department is the Department of Intellectual and Developmental Disabilities. And so underneath that are all the seating and positioning clinics. The vision that we've been given throughout all the agencies is to support all Tennesseans with intellectual and developmental disabilities to live a fulfilling and rewarding life. Our mission within that is to provide seating and positioning improvements for people that come to us. Originally, the Seating and Positioning Clinic provided services primarily to Tennesseans with intellectual and developmental disabilities that also had mobility and alternative positioning needs. The clinic is now open to other Tennesseans with mobility and positioning needs that may not have access to these services and may not have an intellectual disability. There are 3 seating and positioning clinics, one in Greenville, here in Nashville, and in West Tennessee also. So here are access phone numbers and email addresses if you need to get in touch with us. We would really like that. So what do we do here? We evaluate for seating, mobility and positioning equipment. We also simulate what might help a person find optimal alignment and function, because oftentimes those are a balance. We try equipment. We look for things that meet the person's need. We work with the wheelchair representatives to order the appropriate equipment because they're on top of what's currently available in the market. And we also fabricate custom seating and positioning equipment when commercial products don't meet the person's needs. We offer many types of services and equipment. We evaluate for and help design wheelchairs and wheelchair components, fabricate custom bed equipment, sideline, quadruped on forearms, prone on forearms, custom kneeling equipment, and modify commercially available products like bathing and toileting equipment and standers. We help speech pathologists mount speech equipment and also switches to help facilitate communication, and we help design and develop new equipment, sometimes brand new ideas for something specific for one person. Here are examples of different types of wheelchairs. On the far left is a power wheelchair, and it has several different options to it. It elevates, it reclines, it stands, and tilts. And in the center is a little model of a typical fold-up transport wheelchair. We see these often in the community. And then on the far right is a tilt in space wheelchair that's also a complex wheelchair because it has a mold on it. We help adapt commercial equipment, all different types. Just 2 types are represented here. There's a shower chair on the left and then a stander. And the person in the center has a custom lap tray and also custom supports for his knees and his feet. Examples of our alternative positioning equipment that we fabricate here in our building. Sideline is on the left so that the person can literally lay on their side in a structured, supported position. Then to the right is prone on elbows, and as you therapy students know, that's great for bearing weight through your elbows and upper extremity work. On the bottom left is special to this clinic, and it's a custom incline supine piece of equipment. It's like bed positioning on a mobility base, but it's particularly helpful for people that have problem swallowing or problem staying in a supported position at night. Oftentimes, they'll be required to be at a particular angle, but the problems with their body won't let them stay there. And then on the bottom right is a quadruped on forearms. So this is for people that they can't quite straighten their hips. What is therapeutic alternative positioning? Obviously, therapeutic is to help or improve the body's health in some way. Alternative just means other than typical. Other than the typical way the person sits or prefers to sit, if it helps them move into another position. And then positioning is just to arrange. So why are we concerned with alternative positioning? It improves alignment, it helps prevent further orthopedic deformities, digestion, elimination, respiratory function, gains in range of motion. And so let me go back just a minute. Alignment. A lot of times people come to us and their body is positioned in a different way. So with the alternative positioning equipment, we're going to get some elongation, we're going to get some straightening, open that rib cage hopefully, and that's where the respiratory function can increase. We're going to be able to move their diaphragm maybe a little bit better. All these things help maintain their health. The position that I showed you before, anytime you're on your stomach, that helps with digestion and elimination, also side lying. If we can get a person's tone to rest a little bit, they might gain some range of motion, and they also will probably have more function, more access to functional activities, and it just supports their overall health. So ultimately, our goal is to help improve someone's quality of life. How the process works here is a person comes in for an evaluation, and then we identify issues that are important to them or obviously important to their well-being to identify and work on. Then we develop a method of intervention, which will evolve as we talk today. And then the product is delivered. So after the final fitting and all of that, the product is delivered. And then just as important is follow-up. That we follow up and see how this is working for the person, or we give a little modification if it's not quite working in the home as it does here. For the best outcomes as therapists to make sure your patient gets what they need, you want to consider all the factors, at least all the factors that are important to that person. We accommodate for the orthopedic limitations. We're able to acknowledge and respect their tone and reflexes. It just gives us some ideas of where to move from here. We want to balance function and optimal alignment, because oftentimes, when we change one thing, that might change how the person either reaches for their joystick or how they feed themselves, that sort of thing. So one thing can affect another thing. So ultimately, we need to resist overcorrection of the things that this person's been living with. Correct enough, support, and then facilitate function. And it's often just a work in progress. We want to focus on providing comfort so that the person can actually tolerate the equipment. If they can't tolerate it, they just won't use it, and it will be to their detriment too. And the discomfort can continue to lead to more abnormal tone or just not being able to reduce the tone. Their asymmetries, the way their body is positioned, will just increase. As we know as therapists, what is already strong will just get stronger if we don't do some intervention there. If there's the fatigue will increase, or they'll have decreased endurance for use of that equipment if we don't look at what that particular person needs, if we don't accommodate for what they need. And if they're working so hard to stay in the equipment, then they're going to have less attention for the other things that they might need in their life. We've seen a lot of people come in and they just don't have enough energy to finish a meal, and they'll start losing weight because their general strength has gone down. So there are ways that we can help with their mobility to kind of prolong their enjoyment of mealtime. that's just an example. Muscle tone is an important factor to consider when helping someone find what they need for seating or positioning, and also to accommodate for any developmental reflexes that might be lingering around. Muscle tone, what we look for is the quality of the movement of the muscle. So is there too much? Is there too much tightness, or is there too little tightness? Is there enough tension to hold the body upright, or not enough so that they slump all the time and they just really can't lift themselves up? So both of those can cause seating issues. High tone, hypertonia, or a hypertonic muscle, is also spastic, referred to as spastic or rigid. So spastic can be tight at some times and looser at others. It can move with the position of the body. Rigidity is more of a static, permanent position, or at least most of the time. And both of those lead to a lot of contractures. Low tone, hypertonia, tends to be less tone. The person looks soft. They have a hard time holding themselves up. They have a hard time lifting their head. And then mixed tone, categories are athetoid and ataxic. Athetoid is often related to the developmental reflexes because they're moving in and out. So you'll see tightness and then loose, and then tightness in another direction, or looseness and that sort of thing. Ataxic is more abrupt, and there also may be developmental reflexes on top of that, but the causes are often separate. But those look a little bit different, but these things can be overlapping. There might be a person, we see this a lot, where someone has a lot of high tone from trying to stay in their chair, but once you get them relaxed, you see that underneath that is actually low tone. So you have to be able to work within that. So just a few of the reflexes. I know that all of you have been through your neonatal reflexes. The main reason to remember this is that they start in the womb. They start before we're born, and they're normal and they have function. And the function is, in the beginning, is to help the baby learn to practice how to use their muscles before they're born and how to get out of that birth canal. And then later, it's to help them move through developmental sequences. So ATNR helps the child learn to reach for a toy, but that's got to be integrated to bring that toy back. And it's got to be integrated to be able for the person to get a spoon to their mouth. And then you've got tonic labyrinthine, and that helps the child to turn over. So when they're laying on their back, they're going to have a lot of extension, and they'll push off from the back of their head and maybe even off of their heels, and it helps them to move. And then when they're on their stomach, they can go into complete flexion. And that also has to do with the inner ear. Tonic, labyrinthine, the labyrinth in your ear. So it's sort of like a level. And so you'll see with babies, the position has a lot to do with the kind of tone you see. And then STNR, that comes later, and it helps the baby learn to crawl. So when the head lifts, the knees bend and the arms are out. And when the head drops, the knees extend and the arms flex. And the reason that we need to look at all this today is because any of these can present a problem for seating. Any of these can cause a problem, and a person might look like they're sliding out of the chair, and it might be because of one of these reflexes. And then if we know where they start, if we know that we've got a tonic neck reflex going on, then we know we can look at the neck position, and if we can get that neck a little bit closer to midline, then there might be less tone and more midline work. STNR is a big one. You'll see that a lot, where the person will have an extension here, so like they're crawling, and then they put their head down and they're like this. Well, that's not very functional. So we want to try to help them get into the middle there. So we see these cute little babies, and all of this is exactly what's supposed to be happening. So on the left, we've got a picture of what ATNR looks like in a little baby, and In the middle, we've got STNR. She's making her way with crawling. And then on the right, we didn't talk about startle previously. The startle Moro reflex is just when either the baby is startled or something visual happens and they have their arms back and then they come forward. So if that's elicited and they're in their chair and they're not really supported laterally, then they can lose their position. And you can see how if any of these is elicited and then the person can't get out of that position, why that would really impact how we can seat them. And so when our reflexes are integrated, we walk around with them. We're using them all the time. And when we get in a stressful situation, then they come out. But because they're integrated, they go right back in. But we're hardwired. We're hardwired with them to use them. So we want to help our people learn to use them a little bit. And here's more examples of just how our bodies go into those big patterns and come out of them. Going again into some more of the effects, there might be sliding, there could be leaning in one direction if they've got the ATNR in full-blown mode, coughing. Oftentimes, if someone has too much extension from one of those reflexes, then their airway is open and they're having drainage. So we're going to try to help get them a little bit more to midline so they can cover their airway. Safety issues, Moro, arms and legs outside, scoliosis, those spinal curves that JD's going to talk about in a little bit, and then joint contractures. If those patterns stay in one position, then contractures become a real problem and they lead to a lot of pain and a lot of other issues. If a person has a lot of tone and a lot of reflexes that they can't manage, then regular commercial products just really often don't work. And because of the orthopedic and range limitations and because of where exactly they need help with coming out of an asymmetrical position, for instance. So where do you start with all of this information? You just go back to the basics. Whenever you feel like you have too much information, you just go back to the basics, and then you learn as you go, and you approach the situation fresh. So just watch, look, and listen. Watch how the person comes to you. Watch if they're struggling or if they're having no problems. Because if they're not having any problems, then that's information to move forward with too. You don't want to take away things that are working. You just want to add supports. We look at their posture, and then we listen to all the ways the patients give us information. They might be through words. They might actually just tell you exactly what you need to know. A lot of our people are nonverbal, and so we look for all information from a lot of other directions, including body position. How hard are they working to stay in that wheelchair? How many straps do they have on them when they come to you? Movement, how much help do they need to move? Are they completely dependent on someone, or can they move on their own? And how easily do they move? JD's going to talk a little bit more about that also, but that's a very important thing to pay attention to. Muscle tone. How does the tension in their body change with the position of their head and neck or with effort in movement? So our next few slides will show some examples of equipment provided for lots of different types of needs. Each piece of equipment is for that moment in time. Oftentimes we think that once we've provided a service and completed it, that's going to last. But sometimes we have what we call the seating and positioning clinic effect, which means it works here, and then the person gets home and is doing their regular life, and they come back to us with ideas of something that we can adjust for them. And also people change. We all change. We all need something updated from time to time. Molds and that sort of thing, insurance only expects those to last 2 years, and then at that point, if it needs to be updated, we don't have a problem with that. Custom equipment may have to be adjusted and modified for ongoing natural body changes, as well as to adapt to changes in the person's environment. So the other good thing that might happen is you give much more support, and it turns out they're doing so well that they actually don't need as many straps maybe, or perhaps the position of the seat cushion can change just a little bit. And staff, therapists, and family will call and schedule with us when equipment needs to be updated. So here's some examples. We have been so fortunate to get to start working with small children. And this is Pearl. Pearl is using a QOF, which is a custom piece of equipment here, quadruped on forearms. And this works so well for her because she's very stable and she's able to use have her toys and things like that in front of her. She's able to lift. She has much more controlled extension. Pearl tends to extend like the tonic labyrinth thing like we were talking about, and she has a lot of ATNR. And so in this position, she's learning to work in a smaller degree of movement that she can learn to control as opposed to one or the other. And her sister's loving this too. So her mom has been in touch with us a lot and says that she's really enjoying the equipment. Stephanie came to us, and Stephanie and I are about the same age, and she came to us and had never really had alternative positioning. And the chair she came to us with, it did some things for her, but as you can see, there were a lot of things that she needed help with. So like if you notice, her arms are outside the chair, and that's a danger. Her leg is outside the chair here, and you can see here where her arms are. And Stephanie's also a good example of lots of different reflexes impacting her position and limiting her movement. So she's had to work so hard for a very long time that those positions are almost rigid. But let's see what happens here. So this is her new wheelchair. And what you can see is that, let's go back. I'm going to show you this. Look at her arms. And now look at her arms. So there's a lot of flexion, but there's a change in tone. And that's what we look for. You look for changes, you look for relaxation, and what is relaxation for her might not look like relaxation for someone else. There's a little bit more flexion there. She's still outside the chair a little bit, but not much, and she's continued to get other work and some more supports. She has more control here, and she communicates with eye gaze. And she and her sister have this great communication. So we wanted to respond to what she wanted. She still eats by mouth, and we wanted to give her what she needed there. And here's Lakeisha. So in these two pictures, you can see, again, look at where her arms are and look at where her arms are here. So on the right, she wasn't able to use her power chair very well. And over here, she has a lot more access. Look at her deck. Her deck is in much better position and it protects her airway. Her spasticity is reduced. She's got a much better position for her head so that her eyes can see the whole room, and just an overall better position and support. And then here's Lakeisha and her other equipment. She's in a custom incline supine on the left, and that helped her because she had a lot of dysphagia and a lot of problems swallowing. And then the POF, you can see she loves that. She's getting a lot of work there. And then she also had she just had a QOF. I put POF instead there to accommodate for her hip contractures. There have been people that have both, a POF and a QOF, but very rarely. And then she has sideline here, which also gets her out of those positions. So one of the great things about POF is it gets the person off of their bottom, and it gives a place of relief for all that sitting that we do. So TT lived here on campus. So Clover Bottom was a facility where people lived for quite a long time. And then several years ago, everyone moved out into group homes. Right now, but we're talking about TT, and so she lived here at a time, and her intervention only began when she was 32. So typically we think that that might be too late. But this is an example of where everything can help, and small increments add up over time. One of the things I wanted to point out to you here, though, is this is her hand, and the little sock is her foot, and there's her other foot. Just to let you know what she was trying to do to stabilize her body. So she had to be sideways in the wheelchair. You see the wheel? And that's what they had to do to help her get out of bed. But then, so from 1987 to 2010, she's gained weight, she looks better, her legs are down, she goes straight through the door instead of on her side. And that's a huge, huge improvement. She can see what's going on, and she could participate in many more rooms of her house. And Jess, this is the progression of her. So she, in 2004, you can see so much scoliosis, and that's an improvement from when they began. But then in 2012, you can see how it's a much more narrow chair, and her legs are closer to the center there, and she's more neutral, in a more neutral posture. Darren, this is a great example of small changes yield really big results sometimes. So Darren, look at where his head is. He would turn his head all the way around if he could have. And his arms are incredibly straight. So how many reflexes do we see there? ATNR, symmetrical tonic labyrinthine. You see a lot of different things going on there. So when his neck is more positioned off the side, that tone has gone down. He doesn't need the same kind of brace at his knee. His feet are free. He doesn't have to have the little booties because he was getting breakdown. So lots of improvement from a few little things. And here he is with bed positioning. So you can see what he wanted to do. And then he's extending. So there's his tonic labyrinthine and his ATNR all pushing off. And then with his legs more neutral, you have to start at the neck though. Get a little bit more movement there, and then you can bring the knees in just a little bit. And so over time, you can get more range for the person. And then this was dramatic. We do modifications to shower chairs. This was an old shower chair that he tried to use, but you can see he was so uncomfortable and just barely sitting on this right there at the front. You can see where in clinic they tried to build up behind him because they could tell that there was a problem with the seat depth. When they found a chair with the correct seat depth from here to here, not too long, then look at that tone. Look at his little arms. Look at how he's not working to keep flipping around on his left side. And his legs drop. If you can see over there, they're straight, they're straighter. So that's one change. One thing you can do that'll make a huge difference. Jeff really enjoyed his QOF. He's really relaxed here, and now he took naps in it, and JD was telling me that this is how his mom cuts his hair without any problem. Jeff doesn't mind his hair being cut in this position. Jessica had a wonderful experience getting a new bed positioner. When she took it home, that night she slept through the night. And it was also the first night her mom slept through the night. So when we can provide good equipment or good supports, then it can help the whole family. And then here's Julie. we began to open up our clinic to lots of different people, and you saw that we are having smaller children, babies, and then Julie came to us, and she had a spinal cord injury. So she had a full life, and she was a Tai Chi instructor and was doing all kinds of things, and then had an injury that resulted in a C6 injury, incomplete, fortunately, but she left the hospital. They gave her a manual wheelchair, and it was not sufficient for the amount of strength you have when you've had a high spinal cord injury. So we ordered a chair for her that would do lots of different things, because she also came to us with a stage 4 decubitus, which means, if therapist, you're looking at bone. So the big thing we needed to do was get her off of her bottom as many times a day as possible. We had a hard time getting insurance to understand what needed to happen, so we showed them pictures. So on the left, you can see how she's tall. Julie's taller than I am, and she has trouble reaching and doing anything in the kitchen that she used to do. But in a standing chair, she's able to be much more independent in her home and take care of her family in ways that she wasn't able to before. Then her chair was finally delivered right before Thanksgiving last year. And in this picture, you can see how it tilts. So this chair tilts, reclines, because that also helps with the things she needs to do to take care of her catheter, which is also a justification. The good justification always has to do with function, has to do with how that person can be independent. And they also really, it's kind of counterintuitive, but Medicare is really only interested in what that chair can do for you in your home. Sure, they want people to be healthy and get out, but that's not justification in their eyes. So you want to talk about specifically the things that they can't do in their home with their current equipment and what they would be able to do with new equipment. And so sometimes you need to borrow things from a vendor. So you can see there. And then she was able to decorate her tree at Christmas. So this was a great success story, but it took over a year. So my message to you, young therapist, is don't give up and just keep looking and researching for what you need to put into your letters of need. So the end result without intervention is loss of range of motion, loss in functional abilities, increased medical problems, like Julie had a stage 4 decubitus, that sort of thing, multiple respiratory issues if someone can't cover their airway, increased skin integrity issues, and then ultimately there's an increased cost to anyone's insurance. It's an increased cost to the state for those that are supported by the state. And then the worst thing is premature death. Our concerns include that it's difficult for people with these severe issues, these complex, layered issues, to find specialized services through standard outpatient clinics. We're also concerned with Medicare and insurance companies becoming more careful in approving equipment. Of course, they have to be fiscally responsible. It puts another burden, another hurdle in actually getting equipment for your patients. So just know that and be ready. If inadequate equipment is ordered from another source, or if they just go to a dealer and just buy a piece of equipment and it doesn't have enough adjustability, and then they need more supports, they may not be able to get another one for 5 years because of insurance rules. Training's hard for therapists to find for those with severe or complex positioning needs, but it's out there, and the way to go about getting training is just to get as much as you can in any one area, and it adds up. So there'll be training for wheelchair, seating, that sort of thing, and then you'll look for pediatric-based things that will give you information about positioning, and all those things together you add up in your mind. Costs for wound care from a pressure injury or costs from treating aspiration pneumonia far exceed the cost of equipment for the prevention or at least minimizing those risks. So that's also, good justification. Just keep the vision. Every therapeutic interaction that you'll have will make a difference. And small changes can lead to big improvements in a person's quality of life. Just try things. Just try it, and if it doesn't work, you try something else. If you have an idea, you can bounce it off another therapist, and you can find inexpensive ways to work with those things. All efforts to help your patient sit better and more safely are definitely worth trying. And then just read. Yeah, there's so much information, and it continues to change, and the research continues to flow. So just stay on top of it. And feel free to reach out to us at any time. I did want to mention that one of our students from last year kept our number, and this year she had an issue with a family member that has intellectual disabilities, but they did not know about our seating clinics. So she got that person in touch with us, and we were able to help fulfill a need and move him into a more functional chair. So just keep that in mind. We're always willing to help, and we like it. We like doing that. So thanks for your time, and good luck.